Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, the co-founder, executive vice president, and chief medical officer of the CLL Society. Dr. Hilal, can you introduce yourself, please?
Yes, hi, I'm Tilal Hilal. I'm a hematologist and a CLL and lymphoma doctor at Mayo Clinic in Arizona. I also lead the fellowship program there and do a lot of work in CLL.
Dr. Hilal, one of the big areas that has shifted recently because of the potency of the drugs and drug combinations we've seen in CLL is the ability to reach a level where we can no longer detect the CLL in the blood and sometimes in the bone marrow. Can you talk us through just a little bit about what that's about, and then maybe we'll talk about the research that you recently published on that?
Sure, yeah. So this level of detection that we're trying to get to is what we call MRD or measurable residual disease. It's basically a measure of depth of response that is attained by methods that are beyond what we have traditionally used, scans, morphology on bone marrow, and just sort of low sensitivity flow cytometry. So it is a higher sensitivity assay typically that is either carried out in the blood or the bone marrow. It can be a flow cytometry assay, but usually with higher depth. And then there's also NGS methods and other
NGS is
molecular
next,
methods.
yeah,
Next
that's
generation sequencing, which has a higher sensitivity, so it can detect cells at a much higher magnification, if you will. And that usually is around 1 cell per million. So if you have even one CLL cell per million cells, using next generation sequencing methods, we can see that cell, and that is another way of measuring MRD. So there's several ways, and there's several compartments that can be tested, including the peripheral blood, the bone marrow. Um, and it's been utilized in multiple hematologic malignancies now, acute lymphoblastic leukemia.
ask you one thing here because you mentioned the flow cytometry, but that doesn't go as deep, isn't it? 1 in 10,000, is that right?
It's around 1 in 10. Some labs can get to 1 in 100,000. So you can get to sort of 10 to the minus 4, 10 to the minus 5, but it is a lower depth than NGS. That's correct.
And these tests are when you're talking about undetectable MRD or uMRD is how it's sometimes abbreviated.
Hmm.
Um, it could it's sometimes I see there's a number after like -4, -5, -6, and that's referring to that's sort of a shorthand for how deep it's going and what kind of test was used to understand to get to that level.
Right. So uMRD basically says we can't detect it at the sensitivity of this assay. And if it's a flow cytometry assay or a six-color flow, which will get to the 10 to the minus 4, which is 1 in 10,000, if it says undetected or 0%, and then at the bottom it'll say 10 to the minus 4, then you basically know it's going to be at that level at 1 to 10,000. That doesn't mean if you use that same sample with a next generation sequencing assay that you wouldn't find anything at a higher level.
Right.
If you're counting a million cells, you might actually see one there, and it will still be 0 at 10,000. So there is that range, and that's one of the issues with regards to, how do we actually uh, use this in clinical practice? What is the cutoff that we should be relying on? Um, and so we have this big range. All of it is more sensitive than what we used to have. And so getting to that depth of uMRD or undetectable MRD, even when it's at 10,000, it's still considered good or is a positive outcome. But the question remains, do we need to get even deeper? Do we need to get to 0 per million? Or is this good enough?
And I would also add is, and I think you're hinting at this, is that even if it's undetectable, and that's why I like the term measurable residual disease instead of
Hmm.
minimal disease, there's still disease there. If we could go to 1 in 10 million or 1 in a billion, we may find cells there. It's possible that there's no cells left, but in most cases, the cells are still there. They're just below the level of detection, whatever that level is. Is that a correct understanding?
Yes, that's correct. And that's why I think a best way to think about it is almost like a tool to help you measure response and depth of response, but it doesn't tell you there is zero disease in the body. Um, and so I think, as you mentioned, if you go back 20 years, we used to say there's no CLL in your bone marrow if, sort of on the surface, if you don't get into the details, just by looking at morphology in the bone marrow, right? And
Just
now
looking under a microscope, the
under the
pathology.
microscope,
Yeah,
yeah.
yeah.
And now we're able to say there's no CLL at this depth of MRD, but we know that's not the whole story because we know patients who achieve that outcome or achieve that endpoint still likely relapse over follow-up periods of observation. And so they did have disease that we just weren't able to measure.
So why should a patient care about this depth of response? And does it have, I know this is the area of research that you went into, does it predict for how well that patient is going to do in the future? And does it depend on what treatments they have or patient characteristics? Help us understand that.
Yeah, so that's an area of a lot of research that we're doing, but also a lot of trials are now conducting, and as part of their endpoints that they're looking at is looking at that measure and its correlation with outcomes. I think we've known now for a lot of hematologic malignancies for a few years, leukemias being acute leukemias being probably one of the more common ones that people have been really interested in looking at this, and then multiple myeloma as well, that if you achieve that uMRD outcome, um, patients tend to do better. And so it predicts in a way that they are likely to remain in remission longer. The best way to sort of statistically talk about this is to say it's prognostic, right? It means no matter if everything's the same and you give a patient a course of therapy, and at the end of this course of treatment, they achieve that endpoint. And so that means they have zero detected cells at that assay that you used to measure, then they likely will have a longer period of remission than someone who did have disease detected at that endpoint. Um, so that's been shown in multiple hematologic malignancies, and what my research and our group has been trying to do is sort of show this in a way by pooling results from multiple trials and sort of confirm that finding of yes, we do believe it's prognostic, and we kind of have known this in the chemotherapy era, but we haven't really shown it as much in the targeted therapy era. So with treatments like BCL2 inhibitors like venetoclax or BTK inhibitors like ibrutinib or acalabrutinib. So that's what that we tried to do. We pooled prospective trials, data from prospective trials, and looked at progression-free survival and its correlation with undetectable MRD status. And we're able to show that there is a significant improvement in progression-free survival if you can achieve that endpoint at the end of treatment. And this was true in the first line treatment setting, which was the bulk of the data. So if you have never been treated for CLL and you've received a first line treatment with a venetoclax-based regimen or a BTK inhibitor-based regimen as well, even though those tend to be less likely to result in uMRD. But when you pull all of this together, you see that patients who achieve that endpoint will likely have a better progression-free survival. Um, so the question now is sort of taking it to the next level is one is does this translate to overall survival as well? And then two, we still have a little bit of I would say lack of consensus on regards to what's the cutoff we should be using that we talked about 10 to the minus 4, 10 to the minus 6. What is the time period we should be testing for it? Is it at the end of treatment or is it a few months into it? Is it if you're on a continuous therapy, should you do it 18 months into it, 2 years into it. And then the other question is whether um, blood and bone marrow compartments, how much they correlate together, and should we do it in the peripheral blood? Should we do bone marrow biopsies as well? Um, and so all those are sort of open questions, I would say, that people are trying to answer with a lot of sort of upcoming data sets, especially the next ASH that we're going to be seeing.
As a patient, what's exciting to me is we're eager to see new therapies, new combinations of approved therapies move forward. And it would seem to me that if you design a trial and you have to wait for progression free survival or wait for overall survival, which is the gold standard, and I understand that, progression free survival means you're alive, but the disease is progressing, or overall survival is just you're alive, you're just staying alive, which is the ultimate aim. But those can take a long time because we're living a long time, and if you fail this therapy, then you have a subsequent therapy. So the overall survival, the PFS, the progression-free survival, is
Hmm.
it's that box is checked, but the overall survival, you're still living because you moved on to the next therapy. But if we could use MRD, boy, it would seem it could shorten the time for trials. Is that am I realistic in that? Is that one of the reasons we want to understand not only for the patient's benefit as they're being treated in the clinic, but also for a research tool to get some of these new therapies and be able to
Hmm.
assess them quicker and tell patients, yeah, you're really going to benefit from this. It seems to me that's would be a way to accelerate the research in CLL if we could get MRD to be part of the research protocols.
Yes, no, that's a great question, and that's basically what a lot of other diseases have done, is try to convince the regulatory bodies, in particular the FDA in the US, that achieving this endpoint, MRD, is going to be faster than waiting on PFS, which means we wait on a patient to have disease progression, basically. And in a situation like CLL, where the median PFS for a venetoclax-based regimen in the frontline setting is going to be 6, 7 years or 5 years even, you're going to have to wait quite a bit to show improvements there. So PFS for a long time was the shortcut, if you will, to approvals for CLL, right? Because overall survival, even in the pre-targeted therapy era, was decent relatively. Of course, we see better survival now, but PFS became the surrogate endpoint. And the FDA defines a surrogate endpoint that leads to approval as something that is reasonably likely to predict clinical benefit. So if PFS is reasonably likely to predict clinical benefit, then it can be used. And so we have to sort of convince the FDA that MRD is reasonably likely to predict clinical benefit. And to do that, you're going to have to show correlation with PFS and correlation with overall survival when you have it. And the only way to do that is to actually just pool data from multiple trials that test for MRD in multiple settings, and show the consistent correlation. Not only is MRD prognostic, meaning it's going to show you that this patient likely will have a better outcome or longer remission period, but also predictive, meaning if I treat this patient until they achieve this MRD, then they're going to do better, rather than stop at 1 year like we do, let's say, in the frontline setting with venetoclax-based therapy. I didn't achieve MRD at 1 year, so I'm going to extend it to 18 months or 24 months, and then I'm going to stop. And this patient will do better because I treated them until they achieved MRD or uMRD. So that predictive piece is still somewhat lacking in CLL. It's actually MRD guided treatment. We're seeing some trials come out now, and there's some ongoing. But we've sort of shown the prognostic relevance of it. We kind of have to show the predictive relevance of it, and then we have to pull this data together and statistically show to the FDA that, look, this MRD is actually reasonably likely to predict clinical benefit, and then it can be used as a tool to result in accelerated approvals of drugs before even PFS is read. But, knowing the FDA, and maybe things will change in the next few years, accelerated approval remains an accelerated approval most of the time and needs to be sort of converted to a regular approval by confirming something slightly more, I would say, you know, tried and true
Yeah,
endpoint, right?
and
Something,
confirmatory trials, which are
right?
often a long time.
Yeah.
Yeah. So this is exactly what you studied, right? This is
Hmm.
exactly what your research was this pooling together of all these trials. And remind us again what you found, how tight was this correlation? And I'm particularly interested and a little surprised if there's a correlation with the BTK inhibitors because it's so rare to get to MRD, and you did mention that. Yeah.
Yeah, and I think I think the era of continuous BTK inhibitors is sort of dying off. Maybe, we're seeing BTK inhibitors being used now in combination with BCL2 inhibitors for time-limited approaches, and so I'm not sure how relevant it's going to be in the future. It is true that patients with BTK inhibitors who are treated continuously do well without achieving uMRD. And so if you remove them from the pooling of our data, then you see a much more significant difference in PFS because now what you're left with is, BCL2 treated patients primarily. And so whether it's a first line or relapse setting, you see a huge separation in curves between achieving uMRD and not achieving uMRD with regards to PFS. So patients who achieve uMRD will have a much longer PFS. Um, so nevertheless, in this smaller subgroup of BTK treated patients, there was a slight significant difference as well in PFS. I think it's really hard to put a lot of weight on that because it's such a rare outcome for some of these patients. But I think what we were able to show is whether you split it in the first line setting, relapse setting, remove BTK inhibitors or not, you're still seeing a difference. And so this kind of at least supports the first point of that MRD is prognostic. And we kind of knew that in the chemotherapy era, had suspicions here, and we were able to show it in this paper. A follow-up study, well, maybe not a follow-up, but a sort of parallel study that was done by the German CLL study group took it another step further to try and show correlation with overall survival. We couldn't do that because there weren't a lot of data actually for that to be there. A lot of the trials didn't report overall survival by MRD status. So that data was missing, but the German CLL study group had access to patient level data, and so they were able to kind of pool that together, and they again showed a strong correlation with PFS and maybe some correlation with overall survival, although data was lacking there as well. Again, going back to the point, patients live longer whether they achieve MRD or not because they're getting subsequent treatments. Um, so I think we're sort of seeing more accumulation of data sets that are going to eventually lead to this conversation coming back to the FDA do we have enough data out there to support moving this endpoint to in a role where it can actually lead to regulatory approval.
This is really fascinating. It's complicated. There's a lot of moving pieces in this. Any final thoughts or messages you want to give to patients about the issue of measurable residual disease or your research?
I think right now, my approach with patients has been to talk to them about it and talk to, sort of explain why we look at it, what it could mean, what it may not mean, especially in patients who are treated with BTK inhibitors, right? If they're still on it continuously, they're doing well, they may never achieve uMRD. I'm not going to put a lot of weight on that because I know they're going to do well even if they don't achieve uMRD. Um, but I think it's something that will come into the picture with regards, and what I hope will be the endpoint here is that we can actually tailor duration of therapy for some of these patients. The flip side of, okay, you achieve uMRD at 1 year, you're going to do better. Fine, that's a simple way of thinking about it. But what if we can achieve it at 6 months and then stop treatment early? And you can still do the same with regards to outcomes, even though you got treated for a short period of time. And then the other flip side is, okay, maybe I need to treat you longer to get that better outcome. And so you can kind of hopefully get to a point where you're tailoring therapy for patients. We're seeing some of this also, I think, will be presented at this upcoming ASH, several trials that are trying to look at that question. That to me is going to be the exciting part, especially patients who may not tolerate a certain treatment or have a lot of side effects. Cut it short. Don't worry too much about finishing the 1 year. You've already achieved this endpoint. Um, And I think that the regulatory question is going to be something that's going to come up in the next few years. But for me right now, I don't choose my duration of therapy too much with regards to MRD outcome. I talk to patients about it. I test it in the blood primarily, not so much in the bone marrow. And then I ask patients if they're interested in having a repeat bone marrow at the end of treatment. But um, there's a lot of open questions, but I think there's a lot of exciting stuff that are going to come here.
I think this is incredibly exciting, and I think it is the future. And I like the term limited duration rather than fixed duration because it may be limited by it's a year, but it also may be MRD guided. And we
Hmm.
know from the chemotherapy era that what mattered wasn't how many courses of FCR you got, it was how deep that remission. If that remission was uMRD, after 4 courses, you did just as well as somebody who took 6 courses, you know? So
Hmm.
we know it's that depth of remission in the chemo era. And now you're helping us understand that that's also true in the post-chemotherapy era in treating CLL. I'm so grateful for the work that you're doing, you and your team at Mayo, and very exciting, I think very important with strong implications for patients now and over the next few years. Thank you.
Thank you so much.